Very good evening to all of you. I welcome you all for this first activity of the Neuromuscular SIG. And we're starting with final discussion on multidisciplinary treatment of spinal muscular atrophy. Before we start, I would request our President, Dr. Sifaji Gulati, to give introductory comments.
Thank you, Mahesh. As we decided in this term for the EB that we will have SIGs for various conditions, and neuromuscle SIG is one of them. And we start with the neuromuscle SIG academic series. Before that, we were having what the experts say ever since March this year, but now it's going to be every month a different SIG. We have 9 SIGs. And in the next 18 months, they'll come again twice. But in addition to every week, you should wait for something new coming every Wednesday, 8 to 9:30. Please block it. In addition to this, so we'll have different SIGs. Next month, you have neurogenetics and neurometabolic SIG. And thereafter, one more SIGs will come up, and they will have a time coming again after 9 months. But in addition, you will have, please look out for various other academic activities which they will be carrying out, which may be webinars, which may be hybrid, which may be physical face-to-face, and on various conditions, various, like it can be for pediatric neurologists, for neurologists, pediatricians, can be for parents advocacy, for allied professionals. So just keep waiting and watching, and you'll be also being invited to submit cases. And right now, maybe in the next 1 or 2 days, Mahesh will be sending out an email for inviting neuromuscle cases, which will be selected by the neuromuscle SIG, and maybe 2 or 3 may be presented online in addition to the case discussions, and rest we will be asking you to make into video posters, which will be put on the platform on our website. And the website, we plan to have various closed group areas for SIGs. So right now, what we had sent out invite to all our members for SIGs, we did get an overwhelming response with up to 40-45 people opting for some particular SIGs. So what we have done is we have put identified a patron, which we have 9 SIGs, out of which 7 are past presidents of AOCN and 2 are very senior pediatric neurologists, because we have only past 7 presidents. And besides that, we have a convener from the EB, and the patron for the neuromuscle is Dr. Rashmi Kumar, ma'am. And then we have a convener from the EB, which is Renu Suthar from in this EB, and Gurpreet is there for the Gurpreet is there for the otherwise a convener from the non-EB member, and member secretary is Priyanka, Dr. Anita Sharma, Dr. Ramesh Kunanki, Dr. Anup Kumar, Dr. Rajesh, and Dr. Sonali are all members of the neuromuscular SIG. And we are beginning this the last week. We're giving monthly ones, but last was our ending of our pediatric neurogenomics series. So that is why we took over. But we have 5 Wednesdays this month, so you'll get 4 Wednesdays. And just why it is being started as why this SMA has been started, because the SMA, there is an SMA awareness month which comes in August every year, and this is serves as a platform to educate, advocate, and raise awareness about the debilitating genetic disorder which we understand. And the theme for SMA Awareness Month 2023 is Breakthroughs Begin With You. This year, 2023 has come with a special focus on SMA awareness, driven by the breakthroughs in research and advancement in treatment options. This year's themes, Breakthroughs Begin With You, emphasizes the importance of collective efforts of medical professionals, research team, and patients and parents and advocates who are tirelessly working towards the better understanding, treatment, and support for the SMA. And for this, can I have the program again flashed? The panel discussion we have is multidisciplinary management of SMA, and we have it being led by Professor Satish Kadilkar sir, who needs actually no introduction, and Professor Madhulika Kabra, who also doesn't need introduction, Dr. Gurpreet, Anuja, a very senior nutritionist, Dr. Sanjukta with special interest with pulmonology. Professor Bhavuk Garg is very kindly an orthopedic spine surgeon from AIMS, has very kindly agreed to be part of the panel, because very important to have orthopedic care. Dr. Soumya is from PGI, will talk about the physiotherapy and all. And Renu Suthar, our dynamic convener from AB, would be moderating the whole thing. And I think I think Dr. Rashmi is not joined. So, Gurpreet, you want to say some before that, sir? Professor Satish Khadilkar sir will request you for opening remarks, and Professor Madhulika Kabra for opening remarks before I hand over to Gurpreet and then Renu to take it forward. Yeah, sir.
Good evening, everyone. And just to say that it's a fantastic thing to discuss this particular topic. There's so many things that have happened in the last few years. We need to know what has changed. We need to know how, as Indian, in the Indian situation, how we fit into it and what is the way forward. So we must congratulate Dr. Gulati for keeping this as a topic in this particular seminar. And let's welcome everyone. And let's go ahead.
Madhulika ma'am.
Good evening, everyone. So I really thank Shefali for involving me in this panel and congratulate the whole team of AOCN for organizing these very structured and targeted in topics in the neuromuscular disorder group. And I really look forward to learn a lot. And I am sure that this series would be really useful for the pediatricians, pediatric neurologists, geneticists, and other specialists who are involved in the care of patients with SMA. Thank you, Shefali.
Thank you, ma'am. I think Dr. Rashmi was not able to join. Gurpreet, you are our convener.
Yeah, thank you for making me the convener, EB, non-EB convener. I'll be very happy to be the part of it. And this is a very, very important topic, as Dr. Khadilkar has said. We being in private practice are not much aware and not much exposed to the new therapies. And there are so many questions which the parents ask her about gene therapies and all. So I'll be really be benefited from this this SIG, and hopefully everybody else will be. So I invite Dr. Renu to.
Yeah, before Renu takes over, the idea was putting the multidisciplinary thing is you're having debates and talks on the novel therapies which have come up. But, you know, we are chasing the novel therapies only. We are forgetting that the multidisciplinary care is the core, You can't keep chasing and all. Today also, Dr. Madhulika and myself were in a meeting in ICMR about how to have indigenous production of these newer drugs coming for rare diseases. But, you know, we need the multidisciplinary care and support, without which nothing works. I think that is something very important. And also mentioning transitional care and palliative care, which are two very important things, transitioning from pediatric to adult care, which may be there for a late onset, like an SMA, and more so with the DMDs, and also palliative care. We have to understand about that. Renu, it's all yours.
Good evening, everybody, and thank you, Dr. Shefali ma'am. First and foremost, I'm grateful for President AOCN and Secretary AOCN for giving us, our SIG, this opportunity to open the SIG session. So we are very grateful to you. And we have selected this topic because of SMA Awareness Month is going on. And selecting this topic is because parents will jump to us with the asking for therapy. Before that, the 9 things which is required, they often forget. So that's the theme of this session today, that we should re-emphasize that these 9 steps are also important rather than jumping directly to the 10th step. So with that, we can start the session. Can I share my slides?
Mansi, can you give the sharing slides, right? And good morning, Sonali. Thank you for joining from Canada.
Can I share my slides, Sonali? Mansi, can you allow me? I hope my slides are visible.
All good. Please go on.
Yeah. So the theme is today's is multidisciplinary care for SMA. Basically, this is the forgotten aspect of neuromuscular disorder. So the principles of multidisciplinary care for neuromuscular disorder is Similar for all the neuromuscular disorder, SMA is a typical disease which has all the complications which can happen to the child because of severity and variable spectrum of the disease. So we have a panelist of extremely and experienced teachers and mentors and colleagues here. Dr. Khadilkar, ma'am has already introduced them, so we'll directly go to the questions. So just a brief introduction about SMA. We have SMA, which is like every year around 1,500 infants are born in SMA in India, and it is a variable spectrum of disease, and it is a pan-ethnic disease with almost carrier frequency of 1 in 35. The hallmark of the disease is muscle denervation, atrophy, and weakness and loss of motor functions because of loss of anterior horn cell in the spinal cord. And the disease affects all ages with variable spectrum of the disease, where we have prenatal onset, infantile onset, type 2, which are sitters, type 3, which are walkers, tend to lose, and type 4 is adult patients. So whole spectrum of disease is there, which requires a multidisciplinary care. So I'll start with the 3 case scenarios, which is typical. We came across these patients day in and out. So first case is a type 1, where is a 4-month-old child who comes at 2 months in OPD with the history of inability to achieve neck control, with the similar history in elder sibling who died at 5 months, diagnosed an SMA, and he from OPD he doesn't want to come back again. He advised for several of the things, but he presents to ER with rapid breathing, admitted with respiratory failure. But the parents' concern is that they have come across to know about the gene therapy which can be given to type 2 SMA. So their question is that can the gene therapy is given to his son? Should we start collecting money for the same? Now the second case is a 4-year-old child. She's a sitter and 3 copies of SMA, and they came to register to our clinic for rare disease policy support program, where from the this support program they want to have some form of therapy. And type 3 is a walker boy who stopped walking by 8 years and has a scoliosis. He has a contractures. He has 4 copies of SMA and type 3 SMA with the diagnosis, and the parents want to register for humanitarian or compassionate use program for nusinersen or risdiplam. So this is a day in and out scenario in our clinics, where children with SMA comes from far in the hope of enrolling in some or one of the therapeutic programs. So, but none of them is receiving the care which they should be having. So multidisciplinary care is the steps before the therapeutic agents, and it is usually neglected and forgotten. The goal is to optimize biology, functioning, and improvement in the quality of life. So there are several aspects of SMA care. This diagram represents that the 10 steps and 9 steps which are completely forgotten. So before starting for the multidisciplinary care, first question is to Dr. Gurpreet. So how do we diagnose? What are the investigation for diagnosing SMA? How earliest we can think about SMA in presence of clinical features, and what are the standard of care required for diagnosis and evaluation for complication when the patient presents first time to the clinic or OPD to you? Dr. Gurpreet.
Thank you, Dr. Renu. So I'll just start with basics, little basics about SMA. It is, as we all know, it is a motor neuron disease. There is degeneration of motor neurons, and it is a very fast degeneration. If we diagnose it late, most of the motor neurons have already been lost. So we have to diagnose it as early as possible. There are some basic features about all SMAs, that there will be hypotonia, there will be progressive symmetrical proximal muscle weakness involving legs more than arms, and there'll be involvement of intercostal muscles, some involvement of respiration, sparing of the diaphragm, and involvement of bulbar muscles also, and sparing of face. And in SMA, and then there are specific things about other SMA types like SMA 0. So first question is how earliest one can think of about SMA is at birth also. It is rare, but SMA 0 it presents prenatally with decreased in utero movements of the fetus, and then they have respiratory distress needing ventilation at birth. They have contractures and other things like atrial septal defect and all. The most common one is SMA 1, which presents less than 6 months of age, and they have achieved only neck control, which they lose very early. And they also have tongue fasciculations. And older children, SMA 2, 3, they are sitters and walkers, as you have already told. They have some peculiar features like polymini myoclonus, which helps in diagnosis. So the second question is, what are the investigations for diagnosis of SMA? Presently, the gold standard for diagnosis of SMA is genetic testing. We have to detect SMN1 gene deletion by either MLPA or quantitative PCR. So this is the gold standard. It is found, homozygous deletion is found in 95% of the patients. For those in which only one SMA, one gene is heterozygous deletion is there in exon 7 or 8, then we have to go for sequencing to find out mutation in the other gene. And if no mutation is found, we have to think of either non-5q SMA or other diagnosis, where the role of electrophysiology and muscle biopsy may come. In typical SMA, electrophysiology and muscle biopsy have taken a backstage because mostly the genetic testing is very easily available and is non-invasive. Electrophysiology may be helpful in older children where there is confusion and SMN deletion is negative. It may show the nerve conduction may show some reduced CMAP amplitudes, and the EMG would show denervation changes like fibrillations, and chronic renervation changes may also be seen like a large MUAPs. Muscle biopsy, again, it's almost not done these days for SMA because most of the things are either, even if we have to establish neurogenic versus myogenic, then electrophysiology is available. But muscle biopsy may show atrophic fibers. So this is the standard of care, that we first do SMN gene deletion followed by sequencing if we do not find homozygous deletion. It is very, very important to evaluate for the complications because these are the ones which we need to deal before offering the parents Zolgensma and other therapies. So we have to evaluate for respiratory muscle weakness. Involvement of pulmonologist is very, very important to assess for secretions and to be able to assess for coughing ability and the risks for recurrent pneumonias. Then GI involvement is there, for which we have to take help of nutritionist or pediatric gastroenterologist so that swallowing dysfunction can be assessed and treated properly, and GER, constipation. So these can be evaluated at every visit. And then pediatric orthopedician role, we have all panelists. We have all these MDT team is there in the panelists. So for in older children, development of scoliosis is almost universal. So we have to take the help of pediatric orthopedician. So this is how this is the standard of care for diagnosis and evaluation of complications.
Thank you, Dr. Gurpreet. So the message is diagnosis is directed with the genetics, MLPA for SMN1 gene. And at the outset, you evaluate for complication like chronic respiratory failure, oral swallowing dysfunction, bone and spine health, as well as evaluate for chronic respiratory weakness. So, Dr. Gurpreet, is it a practice to get SMN2 copies in these patients? Is it a standard of care now?
Yes, SMN2 copy assessment is the standard of care these days because SMN2 is directly proportional or inversely proportional to the severity. For example, in SMA0, you only find one copy of SMA. In SMA1, there are 2 or 3 copies. Then as the severity decreases, the number of SMA copies are more. So it is very, very important to prognosticate and as well as to direct the treatment. Many of the genetic therapies which we will be discussing are based on SMN2 copy numbers. So that is very important. Thanks for pointing.
Thank you, sir. So we'll move for the next aspect of the care. So the role of geneticist in the diagnosis and management of SMA. So as Dr. Gurpreet has already told that in straightforward cases, it is SMN1 MLPA and you get the SMN2 copy number. These questions are directed toward Dr. Madhulika. Ma'am, the question is that how frequently you encounter patients who had a phenotype of SMA, but they are MLPA negative? And how do you really investigate these patients further with only genetics, or you need further evaluation in terms of other genetic modifier or sequencing or compound homozygous or compound heterozygous variants in these cases?
Thank you, Renu. So regarding the diagnosis, Gurpreet has already told you about doing the MLPA and the importance of the SMN2 copy numbers, because that determines the phenotype. Though, I mean, maybe I'll later on come on that only isolated SMN2 copy number doesn't actually explain the phenotype in all the cases. So first, let us take, when do you need SMN1 gene sequencing? So majority, I think more than 95, even 98% of cases would be having a homozygous deletion of SMN1. And the remaining small proportion of cases will be having a heterozygous deletion of SMN1. So to look for the variation which is there on the other copy of the SMN1 gene, we need to sequence the SMN1. So, and then these patients would be compound heterozygous, which will be one deletion, and other would be a point mutation. So I think very important thing to remember here is that SMN gene, so suppose you have done the MLPA and you found a heterozygous deletion of SMN1 in a patient who's highly suspected of SMA. So here, when you do, say, exome sequencing, in exome sequencing, SMN gene, in the whole exome sequencing, SMN gene is not included by many companies. So I think this is extremely important that when you are sequencing the SMN gene, you do isolated sequencing of the SMN1 gene, or make sure that the SMN1 gene is included in the whole exome sequencing or a clinical exome sequencing panel. So this is an important message that SMN1 gene sequencing could be a targeted SMN1 gene sequencing to detect a compound heterozygous individual. SMN2 copy numbers, Gurpreet has already said that the role is to assess the severity, and for some of the therapies, the numbers are important. If you have two copy numbers, then the drugs are given, and it is standard of care now. So earlier it was a RFLP based, PCR based test, which we still do at times, but then that would only detect the homozygous deletion. It will not detect carriers and heterozygous. So yes, this is the standard of care. Now, as I was saying earlier, it was thought that SMN2 copy number changes are the only determinants of the phenotype. But it has been seen that many of the patients, the phenotype doesn't actually match with the SMN2 copy numbers alone. So meaning thereby that even with less number, you can have a milder phenotype, and with more number, you can have a more severe phenotype. So there are other modifier genes which have been implicated. NAIP is one of them. Associated deletion makes the phenotype more severe. And other than that, there are many other genes which affect the function of the SMN gene, or in the pathway of the this particular gene, the downward pathway of the SMN gene. There are many modifiers. So routinely these are not being tested, and there are n number of them, which include UBA1, SLC23, PLS3, ERK, P10, ZEPAR1, and many more. And usually this is not a part of the routine evaluation, and there are a few new ones have come up. SURF1 is one of them, and very recently it is HSPA8, which has been thought to modify by the phenotype becomes milder if you have variation in this particular gene. This is a mouse experiment study which has come up recently. So why it is important to look at these modifier genes is that if we just say that based on the SMN copy number, we can determine the response to therapy, that's actually not there in all the cases. So if you find some very robust variations, which may be form of a polymorphism or a variations, and then they can also affect the SMN phenotype. So in that situation, because all of the therapies are primarily, if we talk of the AONs, if you talk of that, so if you're talking of risdiplam or nusinersen, it is based on the SMN2 copy number and the modification in the SMN2 gene. So then those therapies may not be effective in a small proportion of cases. And if we know these modifiers, then initially after testing these modifiers, we can sort of prognosticate the patient that what is the likely response to therapy. Secondly, the biomarkers, which are extremely important. One, even for initial suspicion and diagnosis, and again, to sort of follow up the therapy. So it is important that once you have administered any therapy, which could be gene therapy, which could be nusinersen or risdiplam, how do you follow up these patients? So there are There are various biomarkers which have been studied, and in some of the studies where gene therapy and nusinersen, etc., has been used, like expression of the SMN2 protein has been studied. But other than that, there are other biomarkers also which have been used, and a recent one is neurofilament protein, which we are working on to assess the severity as one of the part of our DM thesis recently. Then you can have other markers like CK and creatine, and these are also been investigated and have found to be useful biomarkers. So I think there's an urgent need to find some very robust biomarkers for assessing the severity, because only molecular genetics is not helping us in some of the cases, and also for monitoring the therapy. So I think as of now, I'll stop here, and we can discuss it further. Thank you.
Thank you, ma'am. I think this is very important point which ma'am has made, that whole exome sequencing may not guarantee you to give the other second variant. So because even if SMN1 is included in those panels, the depth of sequencing is very low. So that doesn't guarantee that you get a whole exome sequencing and you can get the second variant. So that is a kind of a misinformation. So we have to get the SMN1 gene sequencing for the diagnosis of compound heterozygote variants. Although there are several biomarkers, but clinical implication of these biomarkers is yet not established. Especially they may have a role when we put these patients on therapy to see how they are actually clinically improving, or biomarkers do show some changes during follow-up. So with that, we'll go to the next scenario. So the case one, who was admitted, started on oxygen, has a kind of features of CO2 retention like hypercapnia. CO2 was 59, BiCARB was elevated, suggestive of chronic respiratory failure. So the child was put on BiPAP with oxygen therapy in emergency and started on treatment for infection. So now this question goes to Dr. Sanjukta. She is an expert in respiratory care of pediatric neuromuscular disorders as well as other allergy disorders. So ma'am, question to you that what proportion of children with SMA like type 1 who have presence with the chronic respiratory failure, and what is the indication to start them on respiratory support? Like sometimes it's become difficult to counsel the parents to start a BiPAP or NIV. So what are the features which can guide us about that these patients are at high risk and need to be started on NIV, and what are the types of NIV and interfaces required? Dr. Sanjukta.
Good evening, everyone, and thank you for having me on board. As you said, I got involved with SMA patients because all SMA patients at when they are presenting to A&E or emergency, they present with respiratory complications. I mean, that's the situation that we all want to avoid through multidisciplinary care. But for the patient that you just mentioned, especially type 1 SMA, it's very difficult because whatever we do, it seems to somehow make its way into that. One thing we have to understand that the respiratory muscle weakness in SMA is it's unique in the sense it's mainly an expiratory weakness where the intercostal muscles are weak, and there is relative sparing of the diaphragm. It's also associated with decreased lung compliance, lung underdevelopment, decreased ability to cough, and usually they all lead to respiratory failure, especially under the setting of viral infections. Type 1 SMA, my experience is that they progress to respiratory failure, and that is usually the cause of their demise. And earlier rather than later, we have to condition the parents to accept it. So how do we understand that patients in SMA, I'm talking about all across the board, how do we understand that they need respiratory support? For type 1 patients who are never able to sit, or the non-sitters or the type 0s, it's very obvious within a short period of time, if they're not receiving any kind of disease modifying agents, even with the best of therapy, they seem to go into the phase where they're unable to cough, They have increased respiratory rate with the typical diaphragmatic use. They are unable to swallow. They have absent gag reflex. They're unable to suck. They have extremely poor weight gain. And these are the time when we have to start with non-invasive ventilation rather than wait for them to go into a phase where they are in acute respiratory failure. For type 2 patients, things become a little different because all of them usually, they are the sitters, they're the better ones. And with multidisciplinary care, they usually do much better nowadays. And with disease modifying agents as well, they are having much better outcomes. But all in all, what happens is there comes a time when we realize that this child is having weaker cough, is having less ability to swallow, and they are having shortness of breath and sleep disordered breathing. So under the multidisciplinary care for SMA patients that we look after, what we do is from at regular intervals, whenever they visit the clinic, they not only have their peak flow measured, they also from time to time have the sleep study done, and in certain cases even where there is a the swallowing test done as well. So when we realize that they are having less ability to swallow, they have sleep disordered breathing, they are having reduced exercise tolerance in the sense of even they are getting fatigued with whatever they are doing much more easily, and they are tending to retain carbon dioxide. So if we do blood gases, they are tending to retain the carbon dioxide, and they're having morning headaches. They're complaining of inability to concentrate in school. They are having decreased ability to clear secretion, and sometimes daytime sleepiness. These are some of the signs we keep on asking them. Sometimes ask them to fill in a questionnaire also when they visit us in clinic. And these children, as you know, the type 2 ones, they're extremely intelligent, so they're able to kind of relate to all these things. And even if they're not giving those indications, personally, I feel that doing a sleep study at regular intervals and also checking out their swallowing and gag functions are extremely important, along with a spirometry, with every visit. And when that is done, we then analyze the values, and sometimes we go in for nighttime BiPAP, and that actually leads to a lot of improvement, and they feel that they are much fresher in the morning, and they sometimes accept it very well. But we are talking of children who are slightly older, pre-teens and teens. In type 2s. In type 3s, obviously the respiratory failure is not something we see very much in the pediatric age group. Maybe when they grow older, the adult physicians may be facing that. The main problem, as you have asked here, the techniques of NIV interfaces and monitoring. Now, the main challenge I face, at least in a situation where we don't have too many centers looking after SMA patients nearby, is the interfaces. The interfaces that we get for children are often not suitable and not the size. I mean, I have compromised by using an adult nasal mask for a face mask for a smaller child, because the nose and mouth covering mask I got was so hard that it was causing pressure sores. So there are so many types of interfaces to choose from in adults, but in pediatrics, especially for SMA kids, it becomes tough. When for type 1 patients, I've used masks covering nose and mouth, and even full face mask. Now, full face mask is not something we really like, because then we are unable to monitor the reflux and the chances of aspirations and choking. And actually the children do not tolerate it well, because they hate that. I think they have a suffocating feeling with that. Though they respond well after some time, for me, type 1 SMA patients, whenever we try to put on the BiPAP mask or the CPAP mask, when they are unwell, they protest as much as they can. So I think there is a scope for developing indigenous and different variety of NIVs for SMA patients. The nasal cannulas do not come in such small sizes for 3 kg, 4 kg children. I mean, they cause excoriation, dryness. So I have tried masks which are obviously see-through, preferably BiPAP machine is used. And there too, we are limited by the number and type of BiPAP machines available and the cost. And my choice is obviously mask covering, preferably the nose only, but the size becomes an issue. So the interfaces are an issue, as I have told you, and the custom made masks are preferable, but some of the companies do, if given the time, measure the size and give custom made masks. And so basically, if we treat the respiratory infections, coming to my last question, prophylaxis, treating the respiratory infections, if I'm to answer that, I think the first and foremost would be the respiratory and chest physiotherapy that needs to be done at home. And that is something that needs to be taught to the parents, to the child, and to ensure that it is done on a regular basis. Cough assist devices are very useful in type 2 SMA patients. And obviously, incentive spirometry is something that I use because children love to blow the balls up. And obviously the vaccinations, flu shots twice a year preferably, and pneumonia vaccinations at regular intervals. And I think what is very important also is to vaccinate the family members and siblings, because you need to break the cycle, especially at home. And the prophylaxis part being important, and other things is that it has been found that even though there is no real data about whether or not you should use regular mucolytics or intermittent mucolytics and nebulizations, there is some scope for using that during seasonal climate changes. So those sort of things should be looked into. And overall, I think the nutritional support is also very important. And I'm sure one of our colleagues will go into that in detail later. So I think for now I will end with that. If we can talk about other details of non-invasive ventilation, like volume triggered NIV, pressure support ventilation, and bi-level PIP later, if so needed.
Thank you, Dr. Sanjukta. I think very important message has come from her. First is regular immunization, and even the immunization of siblings and family member. I think that one is sometimes forgotten during the busy clinic. So I think it's very important to break the chain. Second is putting NIV is difficult in type 1, but type 2 patients may cooperate with us sometime. But important emphasis Madam has given to the prophylaxis, like with the chest physiotherapy, cough assist devices, postural drainage of secretions. So that becomes very important. And
I would suggest that we do a sleep study at regular intervals. Right. That is very important. That is something, a sleep study in type 2 patients at regular intervals, to pick up those who need support during the night, who have sleep disordered breathing.
Yeah, I think we should look for features of chronic respiratory insufficiency in these children with chest deformities, excessive sweating, night-type hypoventilations, frequent infections, swallowing dysfunction. So I think a lot of scope is there for respiratory care, especially in terms of prophylaxis with an early and aggressive treatment of infection, frequent nebulization, requirement of mucolytics is there. So I think these are some key messages Madam has given. I think we can take other experts' opinion also regarding NIV. So it's really difficult field in terms of children with SMA1, especially it's really difficult to keep them on NIV because of lack of good interfaces and patients keep on struggling. They do not like type 2, even type 2 do not like that kind of pressure coming through nose and mouth. So it's really difficult to have that kind of compliance with respiratory support. We can have other experts' opinion also, like how they really face difficulty with NIV in these patients, or respiratory support in terms of SMA 1 and 2. Shefali ma'am, you want to share your experience regarding those?
Yeah, nowadays we are requiring, sometimes for long-term basis, and we are counseling them and ensuring and doing them at home actually. So that has been many times that now. Earlier like if you were talking about 10 years back, we were not doing this, but now since the last decade, many things have changed, and with definitive therapies coming up and supportive care increasing now, and it doesn't take much, it is easy to get this, it is easy, and it is easy to procure, and we can do it on a home basis. Sometimes long term is required, and parents do understand. We have to provide, and they have first is a mindset thing and explain. So this is now, it is very important, like as Sanjukta has said, and it's actually coming in practice. We're requiring all this.
Ma'am, type 2 SMA patients, actually, many of them are on home BiPAP with or without, but they accept it better. The main problem I have is with the type 1 patients when I'm trying to give anything, because of the lack of sizes and interfaces available.
Sanjay, type 1 is very tricky. No, type 1 is very tricky, and it is also
very frustrating.
Very tricky, and it is also, we have to decide when we are going towards palliative and where we want to stop all this thing. And I think I would request Dr. Khadilkar sir, with this vast experience, to, over years, to suggest, what do you think about it? Because now we have started all this, and I think it's helping, but type 1, it's quite a tricky situation. Yes.
Yeah, basically, I think as I look at it, the number of facilities that are able to provide specialized care are so few that that's the real problem nationwide. Not in all aspects of SMA care. Maybe the intensive care unit, maybe the diagnosis and the genetics, maybe even understanding the disease. I think the real problem is a seminar like this will help people, awareness of the people concerned, to really bring it more in tune with where we want to be. Because really the biggest problem I find is awareness, like was mentioned in the genetic stock. So many people send an NGS when they're suspecting an SMA and don't even know which test to ask for. So I think all these fronts are very, very relevant. Particularly the pediatric intensivists are so few that even in the hospital where I work now, we don't always have a pediatric intensivist around. So I think as I look at it, it's more about increasing the awareness and the expertise so that a larger proportion gets the care that it needs.
Thank you, sir, for your insightful comment. Basically, awareness is absolutely lacking. So it's important to identify the features of respiratory failure in this child. Once you identify, definitely certain things can be done easily, like physiotherapy, chest physiotherapy, cough assist devices, postural drainage, nebulization for removing the secretion. So all these simple things can be done before putting down an NIV. So I think it's important to identify these symptoms in this child. And now we'll go to the next.
And Renu, and also, I think these small things like cough assist devices and all that, that awareness and availability, and that all is also lacking. So that is something which Sanjukta may want to add, that the awareness has to increase, and I think we have to ensure that this keeps listed, and whatever the local devices we can have, because we have specific guidelines global which are there. We have to be indigenized. We're trying to think, so we have to see what are available, and it should be available and accessible to everyone, because these are very small basics.
Agree, ma'am. So we'll move to the next aspect of the care. So this is this baby, case 1, who is predominantly breastfed, and in the ER he started on NG feed because of extreme tachypnea, and his growth is flattering. He at 4 months he's 4 kg only. So now the question goes to Dr. Anuja. She's a senior nutritionist at AIMS. So question is that how do you evaluate swallowing dysfunction in these children? The recommendations is that you do video fluoroscopy in these patients in type 1 and type 2. So how feasible this kind of study is? Is it available across the centers? And how frequently they say see dysphagia and malnutrition in these children? And what are the assisted feeding techniques, madam, you offer to these children, and what is the ideal time? Like you start with NG or nasojejunal feeding and then go to PEG or directly to the PEG with. So how do you deal with this complex issue?
Okay. Good evening, everyone, and thank you for inviting me here in this panel. And at the outset, I would like to say that nutritionist in SMA works very closely with the occupational therapist, you know, because so many aspects of swallowing, dysphagia and all that is, you know, it is in conversation with the occupational therapist. So whatever, you know, I'm very lucky to be in AIMS and been exposed to all kinds of diseases. So it is on the job what we have learned, and I'll share my experience. So as you said, this is a 4-month-old child and his growth is faltering, and what could be the swallowing dysfunctions in this child? So for infants, there are frequent complaints of problems with biting. They could be biting, they could be associated with chewing, choking, or difficulty in, you know, crying, very, very weak crying, and problems with, you know, as the child grows older, is it's difficulty in problems with jaws and mastication, biting and chewing, and swallowing often. It appears often with swallowing, in association with swallowing. So obviously, if the child is not able to have enough, malnutrition is inevitable. So malnutrition definitely sets in. And what do we, you know, how do we deal with this problem of malnutrition? Yeah, breastfeeding because of weak suckling in these children. Breastfeeding may not be always possible to give the full amount, and therefore a lot of these problems, you know, he will not be able to have enough feeding and calorie intake. So NG feeding at the outset for a small child could be okay to give whatever the child can have in the breastfeeding, because he'll be too tired to take anything, and he'll have to be nursed very frequently for 5 minutes or maybe 10 minutes, what the child can take, and the rest he may just leave out, you know, because he's too tired. So the breast milk can be expressed and given to the child so that he gets adequately. But still, if his weight is falling and he's faltering in his growth and malnutrition sets in, then even breast milk, or it can be added with the formula milk and given to him, or fortification of various kinds can be done. But it is not like one size fits all. It has to be highly individualized and personalized nutrition. So it has to be evaluated very well, his weight, his length, height, how is he gaining weight, and has to be marked on the growth charts and seeing how is the level of, you know, and what is the intensity of his swallowing dysfunction, and how much he can take, and how much the parents, because it is also very taxing for the mother to, you know, go on feeding him small amounts and then go on making the formulas and all that. So this has to be evaluated along with the parents, and a good clinical history of the child and his anthropometry is required, his BMI is required, so that it can be tracked. And also, you know, because of this fatigue during feeding and unsafe swallowing, short nursing sessions, not being able to finish the feeds, recommended volumes and increased frequency of feed sessions, coughing when drinking, or drinking feeds, or maybe, you know, it may be impaired with a lot of complications and all that. So there could be failure to thrive. And so what is your next question? Yes, what is the acute care of nutrition, right? So I would say that in our practice, the children are given the standard feed as normal children are given. But if the growth is faltering, then we fortify. And it is highly personalized to what level of fortification the child needs, how many times he will be needing the formula feeds, or how many times he could be adjusted to the breastfeeding, or if the breastfeeding is available, can it be expressed, and even breastfeeding can be fortified and given to the children. And also during the complementary feeding stage, when the child goes there, then what kind of food, is it pureed food that the child can accept, or it is semi-solid food? Usually semi-solid or soft food children can take. Otherwise, there are foods which could be leading to problem, like which could lead to choking, and also hard foods, seeds, something like seeds and all that, which could be avoided for children, which can actually get stuck and they cannot swallow it properly. So one has to be very careful the kind of food and type of food they can be given. Also, when the children go up, as they grow up, and it's a long-term, feeding problem which persists, then the peg feeding would be better, because more volumes can be adjusted in the peg feeding, and although children have to be given small amounts at a frequent interval, prolonged starvation also causes a lot of problem in these children. They go into hypoglycemia and catabolic state, excessive loss of breakdown of muscles. And again, a sicker child may get sick. So they have to be fed frequently. PEG would be easier in the older children. For small children, yes, it could be adjusted for some time with NG feeding, but it's a prolonged feeding. When one anticipates, yes, he has to go for prolonged feeding, then PEG would be better and easier for the parents, although the children can just pull out NG feeding, and then again, it'd be a trouble to adjust the feedings and all that. So, and also the supplements, as if the child is deficient in this, supplementation with calcium, vitamin D, iron, and all the other, whole spectrum of this thing can be adjusted, can be given to the children. But of course, nutrition is prime, and that should be optimum as per the age, weight, and nutritional status of the child, and it has to be personalized. Thank you so much.
Thank you, ma'am. I think the important take-home message are like, we need to monitor the growth with adequate charting of anthropometry, regular charting, as well as to assess how safe and unsafe is the feeding of the child. The episodes of choking or aspiration, and if those things are there and growth is flattering, then definitely assisted feeding in terms of NG, and for shorter time, I think NG, and then if you really need a long-term feeding assistance, and PEG may be helpful for these children. And definitely supplements should be provided because of inadequate feeding. I think the question is that how frequently it's a barium swallow which is recommended. So how frequently you do barium swallow, because it's, although it is in the recommendations, but practically I feel it's a really difficult test for type 1 children. So so what is experience regarding this? Should we use this as a test, or you should clinically assess these patients for swallowing dysfunction and then take a call on treatment or assisted feeding regarding that? Any experience regarding barium swallows in type 1 SMAs or type 2 SMAs?
Renu, we don't do barium swallows routinely, and I don't think it's required to do. I mean, that's what I'm saying. We have to just follow up the things. And I think something which is very important to understand is PEG. PEG has to be used really at, where it should be used as a lower threshold, which was not being used earlier. Now you can do it. PEG is easy. You have so many button gastrostomies there. I think their quality of life is very important. And I'll tell you, I had to counsel many parents who were very scared of this and had our pediatric gastro also, who's motivated, also counseling them. But it's taken sometimes a lot of push and encouragement, and then we have, and they themselves have found that the quality of life has improved after that. So I think it's important for that, and I don't think we have to think about going it for barium swallow and all that stuff. Yeah, it's not
if I may just say, some of the assessments which I was reading, which we've not started, and probably as I was reading, we could start for older children, specifically a questionnaire, functional oral intake scale, which along with the occupational therapist, one can evaluate, without even doing any invasive test and all that, and very, very encouraging, which is timed test swallowing and everything. And there's special utensils which can help infants as well as older children to feed very well and prevent malnutrition. So I think we can still work on these things.
Absolutely, absolutely.
I agree, because the recommendations has to be like country specific. So we cannot take all what is recommended. It has to be tailor-made to our patients. Thank you, ma'am, for your experience sharing with us. Thank you so much. We'll move to the next aspect of the care, that is rehabilitation and physiotherapy. So so that has to be like patient specific. So type 1, type 2, and type 3 require different kind of techniques. However, the concept remains same. So like, so I invite Dr. Soumya to just enumerate and tell us what are the concepts and principles. So how do we take these advise these children and parents to start with, and how frequently they should do it to prevent contractures, and how do you advise respiratory care in these children? Dr. Soumya?
Thank you, ma'am, and good evening all. So I'm asked to discuss the basic concept and principle behind the use of physical therapy and exercises in SMA is for maintenance of normal range of movement at the joints and prevention of deformity, which could interfere with the expected mobility or ambulatory status of the patient after medical management. So let us take non-sitters and sitters first. In them, developmental therapy is required for promotion of head control and trunk control. And in case of exercise standing, normal range at the joints is important to compensate for the muscle weakness. For ambulatory kids, proper balance and proprioception is important to prevent falls and to make the gait efficient, to make them enable them to participate in the activities at their age appropriate level. So besides the normal range of weight bearing joints. So it is seen that loss of functional activities is most often attributed to joint contractures, sudden deterioration of the scoliosis, or excessive weight gain. An exercise can have an effect on function, strength, range, endurance, activities of daily living, participation, and balance. So the principle for all of the kids diagnosed with SMA, be it sitters or ambulatory walkers, is to stretch all joints to their normal range and to routinely prescribe passive or, if possible, active assisted range to prevent any impending deformity. The next question is when to start or duration. So I would say earlier is better. It is expected that the child will be struggling to meet normal physical activity levels, and this automatically puts him at risk of developing contractures and deformity. So the basic exercise regime should be started right from the day of exercises and can be a simple regime, a simple homebound program. Standard recommendation is to advise full range and stretching at all joints for minimum 2 to 3 days a week. And the session duration varies from the patient to patient and according to the needs and the joint status. Some equipments or setup may be needed in various positions for facilitating anti-gravity movements. And the recommendation for the ADL independence maintenance is at least 6 monthly clinical assessment of range, strength, and motor functional scales. Now, for respiratory physiotherapy, we have discussed it enough with Dr. Sanjukta ma'am. It involves manual techniques in the form of percussion, vibration, and positioning to promote the postural drainage. Then prevention of contractures. This is the primary objective and achieved by stretching the joints as just discussed, and static stretching and positioning in orthosis for the joints at risk of developing contractures. So orthosis, these are the resting splints or night splints which may be worn during the periods of inactivity to keep the joints in neutral or functional positions. We'll discuss these in the coming slides. Regarding techniques and monitoring for non-sitters, the daily use of seating systems, postural and positioning supports, thoracic bracing and cervical bracing in case there is inappropriate head support. Static bracing of thorax should have incorporated modification in case of SMA children to support respiratory function rather than restricting it, which is a very often came across a complication with the thoracic braces. Then for non-sitters, an overhead frame for springs or lightweight toys may be of help. And the positioning may be done with the help of pillows and wedges. Low load stretching and positioning may be incorporated into age-appropriate meaningful activities. So these are the basic indications for the SMA1 kids who are non-sitters. For sitters, maintaining posture and prevention of scoliosis takes the front seat. Thoracic bracing is recommended, which is TLSO, with or without cervical brace, which is very seldom required. Regular stretching for the segments which are known to be at risk for contracture, which are hip, knee, ankle in the lower extremity, and wrist and hand in upper. So they need assistance in standing also. Hence, exercises which promote developmental motor activities like half kneeling or crawling, they also help. Breathing exercises may be incorporated into play activities. Supported standing is regularly recommended, which should be up to 60 minutes a day and should be regularly done for at least 3 days a week, which optimum frequency is more than that. Ideally, it can be done daily. Then regarding orthosis, they should also be encouraged to use orthosis for supported ambulation. This we'll discuss later in the orthosis part. Also, there are some possibilities of assisted ambulation for the kids who are otherwise non-sitters, but not able to walk because of the weakness. There are some orthoses which may help, that we will discuss later. Besides this, some aerobic exercises like swimming, hippotherapy, and wheelchair sports may also be introduced in these kids. Electrical power wheelchairs are recommended for them right from the age when they started lagging behind their peers. This we will discuss later. And lastly, the ambulatory group or the walkers, they need some additional help for balance and proprioception for maintaining their ambulation. So a good aerobic and general conditioning program works for them. There are various options that should be chosen from, include swimming, walking, cycling, yoga, hippotherapy, rowing, cross trainers or elliptical trainers. The optimum duration that should be advised is at least 30 minutes a day, ideally daily, but minimum 5 days a week. Then for stretching, the minimum frequency is 2 to 3 times a week, and it should be done to maintain the flexibility for all the joints. Orthosis use may also be incorporated for providing a static stretch. And for ambulatory kids, for postural control and prevention of scoliosis and hip dislocation, positioning and bracing is very important. Balancing and proprioception exercises are recommended, which are some simple exercises which can be done at home just by teaching the patient or the parents. And lower limb orthosis, they are used for the posture maintenance and to maintain the function at ankle and knee, which are at times because of decreased activity level, develop some deformities, which may be avoided by using the braces. Thoracic bracing in these kids should only be used to promote posture in sitting, because otherwise in ambulatory kids, it has been seen that the thoracic braces are very restrictive. They reduce the respiratory function as well. They become so restrictive that patient find it difficult to walk because it increases the energy consumption during the eight also. So it should also be only be prescribed for maintaining of the posture in sitting and for the minimum duration. The remaining orthotic options we'll discuss later. I think we may go ahead, ma'am.
Thank you, Dr. Soumya. Those are the key principles are to maintain the range of motion across the joints, provide stretching to prevent contractures, as well as active and maintenance of respiratory function with kind of respiratory therapies should be advised to all these patients, and they have to be tailor-made according to their physical status. So with that, we'll move to the next, bone and spine care in these children. So we do see frequent scoliosis in type 1. Type 1 rarely, but type 2 very frequently they develop scoliosis and contractures. So this question is for Dr. Bhavukar, who is Associate Professor of Orthopedics at AIIMS and has a interest in spine surgery. So this is for you, sir. So how do we monitor spine and bone health in these children? How frequently you do get AP and lateral views, X-rays, and to monitor the corpse angle? And when do you advise to start using of spine braces?
Thank you, Dr. Renu, and I thank Dr. Shefali for this opportunity. So actually, the neuromuscular scoliosis is actually a very big, forms a very big chunk of patients for us. And the SMA is, fortunately or unfortunately, forms a very small portion of these neuromuscular scoliosis. The reason is that the SMA is basically becomes as a secondary care provider. The survival and the other major issues that remain the more problematic for the caregivers. So rightly said, the type 2 SMAs, they present to us more frequently with these problems. There are various causes I'm not going to detail. But yes, the scoliosis is found in around 90% of the patients with type 2 SMAs. And they also develop these contractures. In the upper limb, we talk about the shoulder is the most common joint. In the lower limbs, the knee is the most common joint. And they usually, as Dr. Soumya said, we start with physiotherapy and stretching. And if they don't work, then we move to the serial castings. We try to correct them with casting, or we give them braces. And sometimes we have to go for surgical procedures as well. Coming to scoliosis as such, the definition of scoliosis is that it has to be more than 10 degrees. So sometimes the many people, they come to us, especially with type 3 SMA, that my child has got scoliosis. But actually, if it is less than 10 degrees, then we don't label it as scoliosis. It's a normal variation. So when up to 15 to 30 degree, we just focus on exercises and physiotherapy. There are certain scoliosis related exercises which we focus on. Once it crosses the level of 30 degree, then the progression is very rapid. So the problem with scoliosis in these children is that they are already at disadvantage from the pulmonary point of view. And scoliosis, it decreases the vital capacity. It also, their ribs, if it is severe, then their ribs, they start touching the pelvic bones and it becomes very painful. That pain secondarily inhibits their breathing capacity. So again, this becomes a problem. So once this reaches 30 degree, that is our indication of starting the bracing. So from 30 to 45 degree or 50 degree, we use braces. But again, the braces, they are not very effective in this group of patients, I must say. The progression is very rapid and we have to keep monitoring it. So we usually call them every 5 to 6 months to get the X-rays done. We usually rely on the AP and the lateral X-rays. In the initial stages, we may get bending views to look at the flexibility also. But usually we rely on AP and lateral at 6 months follow-up. And we do give them braces. We don't prefer the soft braces because, again, in my opinion, they don't work. We give them rigid braces. But again, there is a problem because some of these patients, they may get breathing difficulties because of these braces as well. So again, you have to see and monitor these patients very carefully. The other problem with these early, if they present early, less than 6 years of age, then if we operate them, if we do surgery, then the chances of complications are very, very high from the hardware point of view. The bones are not so much formed. They are not so much strong that they can hold these screws and rods. So the chances of failures, they're very, very high. So we tend to delay it preferably by the age of 8 years. After the 8 years, the chances of successful surgery, they're very, very high. And in these cases, again, we may rely upon braces to prevent them. See, the indication of surgery is 50 degrees. So if an 8-year-old child comes with 50 degree corpse angle, I will straight away go for surgery. But if a 6-year-old child comes with 50 degree curve, then I will try to delay it up to the age of 8 years. And if I can get a 60 or 70 degree curve, it doesn't matter to me as a surgeon to correct a 70 degree curve versus a 50 degree curve. So I can correct it both the curves. So again, we tend to maximize the reserve of the body. Now so the indication of the spine surgery remains if it is more than 50 degree, preferably, and we tend to delay it up to the age of 8 years. And usually we have to also see whether the patient is ambulatory or non-ambulatory. The level of extent of fusions, the levels of fusion, they also depends upon the ambulatory status. So if the patient is non-ambulatory, then we always fix the pelvis as well. The problem with fixing the pelvis is that we make these child longer, and because their upper limbs, they are weak. So, it may actually decrease their functional capacity as well. So you have to assess them thoroughly and how much, the height gain will affect their functional capacity, that has to be taken into consideration as well.
And second question is, do you frequently come across hip dislocation and osteopenia, and how do you monitor and treat these fragility fractures or osteoporosis in these children? Because of lack of mobility, poor muscles, bones are usually
Again,
ill-formed and they are weaker.
So the fractures as such, they are very rare in this population because they are not mobile usually. They are not this thing. The joint dislocations, they are fairly common. The reason, again, especially in non-ambulatory children, because of this scoliotic deformity, there happens the pelvic obliquity as well. And when the pelvic obliquity happens, and because of the muscle weakness, then the joints, especially the hips, they tend to dislocate. And again, the options of operating them the outcome are very, very poor. So the only option remains that you correct this pelvic obliquity by correcting the spine deformity. This thing. So again, if there is a pelvic obliquity, again it becomes an indication for surgery in this population. Fractures, we rarely encounter this population as such, and we usually give them good nutrition, and we give calcium and vitamin D. So I think I have not seen any fractures till now, which are treated for SMA.
I agree, because of lack of mobility, we do not see fragility factor, but the bones are usually weak and osteoporotic in these children. So definitely calcium and vitamin D is required.
So,
Dr. Suthar, may I have a question for Dr. Garg? Is it possible?
Yes, ma'am, please go ahead.
Yeah, because I have seen fractures in SMA patients type 2, falling down from the wheelchair, trying to do some acrobatic stuff. Children try their best and then fell over and broke the hand. And it's very difficult to fix these things. And I have seen SMA experts regularly doing DEXA bone scans and going for zolitronate infusion, and have incorporated that in my SMA care of patients. I would like your input regarding that, and Dr. Garg's as well, and Dr. Gulati's, what they feel about this, doing DEXA scans and going in for zolitronate infusions, other than obviously vitamin D and calcium.
So, ma'am, the DEXA scans, we can definitely use them. But again, there are specific groups, and we have to take care of them individually. So the patients who are non-ambulatory, for any reason, they always become a risk factor for fractures, because their bones, they get osteoporosis because of the lack of mobility. So not per se from the SMA point of view, but because of their non-ambulatory status, they get osteoporosis. And once they get the DEXA scan, we can use for diagnosing the osteoporosis, and we can use the Z score. We don't use T score in this pediatric population. So if we are using Z score, then again, with the help of the consultation with endocrinologists, in these non-ambulatory cases, especially in chronic spinal cord injury patients, we do use zolitronic acid because we don't have any other option of anti-osteoporotic drugs. We cannot use teriparatide in this pediatric population. We cannot use the denosumab usually. So these bisphosphonates, they remain the mainstay of treatment of osteoporosis in this population. And again, treating them is a problem because of these contractures and this thing. And we have to devise, the specific method depending upon the patient to patient.
Thank you, Dr. Bhavuk. I think we agree. The DEXAs are usually now in guideline also, they recommend DEXA in these patients just to monitor. And if you have Z score which are less or spine compression fractures, bisphosphonate can be used in these patients. So thank you, sir, for that. Now the question to Dr. Gurpreet is again, sir, I'll ask you to just elaborate on immunization. I think he has already covered this one, because regular immunization with the pneumococcal and influenza vaccine is recommended in these children. We should ensure that they should receive it in either primary, and if not received, then we should give them. So now again, I'm coming back to Dr. Soumya for orthotic devices. So some of the devices like routinely prescribed to these patients are like night splints, AF4s, braces, and what kind of mobility devices can be used by these children. So I think we can focus on type 1 and type 2 SMA. Dr. Soumya?
Yes, ma'am. So, okay, beginning with AFO. AFO splints, they are probably one of the most commonly prescribed orthotic device. And primarily there are two types of AFOs. First one for use while resting or as a night splint, which is aimed to prevent the equinus. And second one is like is a shoe insert, which assists in gait. So in non-sitters and sitters primarily, which is used for the prevention of deformity and facilitate exercise, standing and weight bearing activity. It is resting AFO. These are solid AFOs with anterior cutouts beyond the malleolus at ankle level. So they have two benefits. One, they prevent the deformity because they are quite restrictive, definitely. And another is for these kids, they can assist in the complete placement of foot over the ground and hence exercise standing. The other ones, which are shoe inserts, they are relatively lightweight and meant to be used inside the footwear to facilitate near normal gait, which are certainly not the typical prescription in SMA children because peripheral is rare to see. Now, for non-sitters, daily use of orthosis for upper or lower limb is for stretching and to promote function and range also. So static orthosis include knee mobilizers and hand sprints also besides AFO. These are recommended regularly for positioning and static stretching. For lower extremities, besides AFO, the ankle foot orthosis, knee ankle foot orthosis can be used because at times it is seen the primary deficit lies in the anti-gravity muscle at knee, which is quadriceps, and that is very restrictive because it doesn't even allow the kid to stand on his own without, if he doesn't use KFO. So KFOs are at times a wiser choice to prescribe. Third one is TLS, or the thoracolumbo-sacral orthosis, the spinal brace. These are primarily used for positioning while supported sitting. To be effective, any orthosis should be applied for more than 60 minutes, at least, ideally overnight. And the minimum frequency that we advise is 5 times a week. Ideally, it is daily for maximum hours of the day, but minimum is 5 days a week. Now, for sitters, about thoracic bracing, Dr. Pavuk sir has rightly mentioned that the soft ones doesn't help and rigid ones are provide undue restriction. So it's a difficult decision to make. But thoracic bracing in these kids is recommended for posture and promote the function, activity of daily living, not the walking typically. Cervical bracing is also used for head support, especially while traveling and doing some activities which are out of the routine. Orthosis for upper and lower limbs, which are used to promote function and range, are similar to the non-sitters, like the ones for upper extremity are wrist hand orthosis, and for lower extremities, they are AFO and KFOs. For sitters, there are reciprocal gait orthosis. This is nothing but a KFO with some slight modification. It imitates the reciprocal movement of the lower extremity, which is of help for some kids who have enough power in the lower extremity, at least 2 power or more, to imitate the normal gait pattern, so they can walk with the help of a walker and RG.
Soumya, can you expedite? Actually, we are
Sure.
coming to the end and we
Sure,
still
ma'am.
have 2 segments left. Huh? Sorry.
I'll take
I know we
30 more
started 10
seconds,
minutes
sir.
left.
Yeah, let us just enumerate okay, this was about the orthosis part. It is almost over. Then comes wheelchair. There are many types of wheelchairs for these kids. The primary ones that we use are electric or powered wheelchairs. And then the light framed wheelchairs, which may be used by the walkers and which the adult walkers typically. They are to be customized according to the height and age of the child, and these are recommended. Basically, the parents should be counseled for they should be encouraged to use wheelchairs rather than restricting the children to restricting their interaction with the society. So, I'm open
Thank
to
you, Dr.
questions.
Soumya. I think it's very important that parents should feel empowered with use of wheelchair, and patients should also feel empowered rather than feeling it is some kind of a taboo, which is a common feeling in most of the patients, that they do not want their child to be on wheelchair, but it provides them mobility and freedom also. So now moving to the next most important question here is disease modifying therapies for SMA. So I'll ask Shefali madam to just tell us about how to appropriately select and what is current experience in India.
Thanks, sir. Renu, I'll do it. I'll just touch it briefly. Before that, Dr. Bhavuk, I would like to ask you a question which is there in the chat. Good evening, sir. On follow-up visits, how many SMA kids tolerated spine surgery? Some papers say they tend to worsen on the motor scores. Have they shown improvement on your follow-up? Abhishek Pandey, Dr. Abhishek Pandey is asking this question. Dr. Bhavuk. Dr. Bhavuk, are you there? Dr. Bhavuk? Okay, I think...
I'll message him, ma'am. Meanwhile, we can take the therapies and later on we can take this question.
Yeah, fine. No, I just thought that because he may want to log out. That's why I was asking. Yeah, it's fine. No problem. If any joins, he can ask anytime. Basically, just very superficially and just for mentioning that most important thing, what it happens is that SMN2 is the backup gene. And that is what is important and where we are mostly targeting our treatments. That is why you need to know the SMN2 copy numbers, and that is why you need to have the test done and you need to have the right test done, which has been mentioned even in the last couple of weeks. We've been having so many series of talks on which genetic test and when and all. And as very rightly pointed out by Dr. Madhulika, what is important. So SMN2 generally produces only 10 to the 20% of the working protein compared to SMN1. And basically there is a basically C22 mutation, a C2T mutation in the exon 7, which causes the exclusion of the exon 7. And that is how it is. And what is the potential therapeutic strategies to identify the agents which are going to prevent this splicing event. And chronologically starting, nusinersen was the first FDA approved in 2016, which is an SMN2 directed antisense oligonucleotide, but it has to be given intrathecally with 4 loading doses initially. First 3 are at the interval of 14 days, and the 4th day is 38 days after the 3rd dose, and then maintenance 4 monthly lifelong. It's intrathecally given, can cause thrombocytopenia, coagulation abnormalities, renal toxicity, and we have not seen in the experience of not many side effects. I'll just mention the experience simultaneously with the things, but the whatever it has happened with this ASO, they have shown that the early treatment may maximize the benefit in these patients, and all of them have had a good response. And when you pick doing the SMN1 patients who are in the first 6 weeks, the treatment response has been the best. The pre-symptomatic stage, in the infants less than 6 weeks, basically that was a maximum benefit which has been noted in these patients. And now they are trying to do long-term studies and trying to see and give nusinersen in those patients who were actually given Zolgensma earlier and have not much improved also as going on. And in the pre-symptomatic infants, they have had us follow-up of up to 4.9 years and tried to see that whatever has been achieved has been maintained. So, that is a point that is something to be very reassuring. And right now they're trying certain combinations of those who have already been given, Zolgensma in the past. But coming to the we have experienced with around 12 plus 35, 47 patients, and over a duration of, we started in 2019 December end, and out of all these patients, about 47, they all are showing improvement in motor milestones, which is there, but there's nothing magical about it, but they have been there and progressively, because they have been monitored by HFFSC, and they have classically, over a period of time, the Hammersmith scores have been increasing, and their milestones have been improving. Next is that Zolgensma, which came which was FDA approved in May 27, 2019, and which is $2.125 million, and this actually, it produces the functioning SMN protein, but it does not become a part of the child's DNA. So what it is being done, that it is it has been given along in the AAV9, but it is not becoming a part of the child's DNA. So we do not know that, whether it's got the longevity and the duration for whether it's going to be there for lifelong. And it is a single dose intravenous infusion, and you need to have anti-AAV9 antibodies negative. LFTs are deranged in most of them. In our experience, also platelet count may be reduced. Troponin of the cardiac function also has problems, and you have to prime with prednisolone equivalent 1 mg per kg per day started 1 day prior to the gene therapy. And you may have raised OCPTs, thrombocytopenia, and elevated tropi, and which we have also seen in pretty many of them. Basically, in all the studies which have done, even in this, they have shown that the earlier you give, the better it is. So again, this is becoming reiterated, and the smaller babies, they have done the CHOP intent scores, which have been used and has been used for monitoring. And now currently they are doing a long-term 15-year trial from 2020 to 2035 to see how long the duration it is going to be there. And then there was a study in which they were trying the intrathecal Zolgensma, but then there was some safety concerns, and that is why it was stopped in between. And there was some inflammation in non-human primates, but now it is again been started. But again, one of the trials of pre-symptomatic SMA were the best response which have been seen. So, as it's important to understand the long-term follow-up, which I mentioned to you, and many of them have had improved, bulbar function, the swallowing functions, all of them have been shown to improve. Coming to the third drug, which is risdiplam, which is an oral medication. I must just say that the nusinersen was, which was there from the beginning, was approved for all ages, except that there was a problem if you had severe scoliosis with the Baddock-Cobb's triangle, then you could not actually administer the drug in many of those advanced adults or grown-up children. But it was approved for all ages. Zolgensma has been approved till up to 2 years of age, or till up to 21 kgs by the European Union. Its FDA is approved up to under 2 years of age, but the European Union gives the doses up to 21 kgs. So currently there is there's a trial going on from the age group of 2 to 18 years, and out of which actually they were in 2 aliquots, 2 to 5 and 5 to 18, and it was not intravenous, but it was an intrathecal administration in this one. We have already completed enrollment from 5 to 18 years. Currently enrollment is some little bit pending, is 2 to 5 years globally. So this is now and we have had experience basically with around 15 patients with the Zolgensma, and the first patient with gene therapy in India on 29th May 2020, the peak COVID time was there, and the child is also doing well. All of them have gained motor milestones, but he was SMA type 2, and he's now being able to walk with gaiters. But yes, with proper OT, PT, and getting support from the nutrition, all of them have nutrition plans, diet plans made, and periodic follow-ups with Dr. Babu. So, but in all of them, we have had raised OTPTs, and in some we had to extend the duration of steroids to up to 6 months as well. But and for thrombocytopenia, we've had some thrombocytopenia, but only one patient I remember who required a platelet transfusion. Coming to risdiplam, which is also, it was approved on 7th of August 2020 by FDA, and was approved for more than 2 months, more than 2 months of age. And then there was in many other countries, and then in India it was approved and launched in July 2021. And it is an oral drug. Again, it's an SMN2 splicing modifier, and it is given orally. And it is given in an amber color bottle. It has to be reconstituted by the physician, and it has to be given, and it can cause some fever, diarrhea, rash, and after ulcers. We have had experience in some 9 patients so far, and none of them had any significant side effect, but they also had the similar pattern of gain in motor milestones. To begin with, they had done studies, and they found all of them had significant improvement in motor milestones. But then the recent study which they did, which was published about, the results came last year, which was the rainbow fish, in which they did from birth to 6 weeks of age. and they found that infants treated with risdiplam were obtaining they were obtaining milestones which were age appropriate at 12 months of age if they were treated in the first 6 weeks. So this becomes important, and that's why on January 24, 2022, FDA re-looked into the less than 2 months, and on May 30th, 2022, it was approved for even less than 2 months of age. So risdiplam is approved for all ages as well. Right now, there have been trials in which they're trying to give and mix and match various of these therapies. Just we need to know the cost implication for Spinraza, which was, I told you initially, you have 4 loading doses, then 4 monthly lifelong. It costs around 4.2 crores for the first year and 2.1 crores thereafter. So Zolgensma becoming around 2.125 million US dollars, around 16 to 7 crores. And risdiplam, which came to India, was 2.5 crores per year for a 20 kg child. But now the company Roche has brought some packages for the parents that you buy so many bottles, buy so many free. So it comes to be 72.8 lakh per annum for a 20 kg child. The Blue Tree program. There's some new drugs like Brenalapram, which is again a SMN2 splicing modifier, which is being studied in SMA type 1 patients. Another new drug which has come up is Epitogromab, which is also being studied. And there's a lot of combination therapies are being studied. You may think that they're exorbitant. We're talking about combination therapies. I'm not talking about only combinations between Zolgensma and nusinersen risdiplam. The point is, if you have at different aspects, like you're giving an SMN1 gene delivery by Zolgensma, but you are having a SMN2 mRNA, splicing modifiers in the form of nusinersen and risdiplam. But you may also have increased expression of SMN2 by histone deacetylase inhibitors. So you may have certain other things which can be explored, and the combination therapies can be seen. In the earlier those of Zolgensma who were not getting that much response, whose response had sort of plateaued after Zolgensma, have been tried on nusinersen as well as risdiplam, and shown to be having beneficial results. And right now, there is nothing much in the stem cell front, which is very important to understand for SMA. This thing. So I think it is, we have to remember that the many new therapies are there, but you have to have the multidisciplinary management, which is very important. And that will be keeping in mind that those who are the bigger children who are going to cross into the, from the adolescent to become adults, that we are going to provide a proper transitional care with the whole team of the pediatric to the adult team. And that doesn't happen one day. It happens gradually over a couple of weeks. And other thing is palliative care, understanding at what time we should stop chasing the aggressive, definitive disease modifying therapies and provide palliative care with all dignity and respect, and, and humanistic aspect to be kept in mind for all these patients. I think I will want to ask Dr. Madhulika, what is the status of newborn screening, and what do you think it would be? And something very important is, and it is complex, it's not simple, be keeping in mind that it's not a simple autosomal recessive genetic counseling you would like to do. So Dr. Madhulika ma'am, I would ask you 2 questions. Where do we stand for newborn screening, A, and B, what are the salient points in genetic counseling do you keep in mind, and how far are we from pre-implantation genetic testing and pre-implanting genetic diagnosis? Before I would request Renu to ask take home messages from all, and meanwhile we answer the queries. Dr. Madhulika, you can stop sharing the slides, Renu, I think, or you want to put the next slides? I think it must be this. I just wanted to wind up. Yeah, that is there. Next, it's okay. You can stop sharing.
Yeah. So Shefali,
Yes.
we all know
Stop
that
sharing.
it's autosomal recessive disorder, so risk of recurrence is 25%, and prenatal diagnosis is straightforward. So the earliest would be around 11 to 12 weeks of pregnancy, and CVS is taken, and we have to have a confirmed diagnosis in the affected child, and it can be offered. The second thing is about the newborn screening, which has come up in the Western world because of the availability of treatment, and they have accessibility to treatment also. Like in the US, it's insurance, and in In UK, I think it is through NHS. So particularly in US, there are many states which are offering newborn screening, and it is very feasible. The test can be MLPA can be done, and there are cheaper tests also which can be done based on the quantitative PCR and digital droplet PCR, and this can be done. But the main issue is the cost of testing is high if you do it as screening. But the more important thing is that once you make a diagnosis early, then as a principle for newborn screening, we have to treat these children also. So it is important that if you start doing newborn screening, then you have to have ability to treat, which may be risdiplam, it could be gene therapy. But as of now, that is a question that we have, that as per the government policy also, that the funds which are being provided to these patients will not be enough treat these patients. This is important, and it is extremely important. And you also mentioned that the best outcomes with gene therapy or any kind of therapy would be that the therapy is started within first 6 weeks of life. In fact, for newborn screening, when the patients who were screened by newborn screening, their outcomes were like normal children only. So that is important. Now, another very important aspect which you touched upon is carrier screening. For antenatal or even preconception carrier screening. So SMA is emerging out as the next most common autosomal recessive disorder in India after thalassemia. So as you must be knowing, there are 2 studies. One is from Gangaram Hospital and another from SGPGI, where they have found that the carrier status is about 1 in 40. For thalassemia, we say it is 1 in 25. So it may translate into something like the frequency may be, the prevalence may be 1 in 4,000. It's a very, very high frequency. So there is a lot of discussion about carrier screening for antenatal, for spouses which are not at high risk. So people are now talking about screening as a routine, as we are doing for thalassemia. So I think after thalassemia, SMA is another entity where we can offer carrier screening. And if the parents are interested, we do tell them that if you're thalassemia, we are doing for all. SMA we offer in case they ask, and the other ones like Fragile X and DMD is also on the line. And then even exome sequencing, people are saying that even in low risk pregnancies or low risk couples, it can be offered, but it's not a standard of care as of now. About population screening, as of now, I think it is not being practiced, particularly for carrier screening. It is primarily for preconception screening it is offered. And the fourth part is the pre-implantation genetic diagnosis. Shefali, theoretically, it is possible, but in our country, I'm not sure whether they are giving pre-implantation genetic testing for SMA. They are doing targeted pre-implantation genetic testing with the help of some labs abroad, but most of the time it is restricted to say chromosomal disorders and some of the specific monogenic disorders. It is possible for SMA.
India में thalassemia में तो हो रहा है मैम.
Thalassemia में हो रहा है, and even targeted when parents have been found to be carriers or previous affected child is there. So that is PGDM for monogenic disorders, and then you have for aneuploidies that is being done regularly. Even for chromosomal abnormalities, structural abnormalities, it is being done, but it's not very, it's expensive also as of now. PGD is expensive.
Yeah,
so I think that's in brief whatever you have asked. Thanks.
Yeah. Thank you, ma'am. Sir, Khadilkar sir, now tell me about what do you think is the ethical issues which ma'am raised. If we do newborn screening, we need to treat, and the cost is so expensive. And other thing is, Sayukta has asked a question to me that she has a type 3 patient who is on nusinersen, is married, and wanted to know whether she has to stop injections, have a child. I'll have to read about it and revert, but I thought you must have faced a question similar with your experience. If you have faced, and otherwise, whatever your comments are. I thought, Sanjikta, I'm asking sir because I think he has maximum experience in that age group. Yes, sir.
Sir, you are muted.
Mute.
This particular issue haven't come in front of me as well, so I will have to look it up myself. These are very difficult issues, and the deeper you go in them, the more difficult it becomes, because it's nice to say that we'll do a screening program and we will sort of pick up. Once you pick it up, what will you do with them? What are the facilities? How much can you really try and help people? So in fact, one good deed can lead to so many more daughter questions that it's like a never-ending tree. And frankly, if there's a paper now will be probably published later this year in Neurology Clinical Practice, where in some 30 odd countries, they actually took experience of what are people able to do. How many countries have the ability to give nusinersen and the other Zolgensma and other medicines is abysmally low. So in fact, the ground reality is that while these things are surfacing, really they haven't as yet been able to make their presence because they are so expensive, and the way they have to be delivered also needs expert care. So I think that underlines the importance of a program like today, where we really have to focus on the very basic aspects of the disease and a multidisciplinary approach, and not be too enamored by the so-called new treatments. While they're there, and I'm sure in time to come they will get better, and they'll be more effective, and they will be less expensive, and they will reach everyone. At this point in time, I think it's just the tip. It's just the tip, but what you really need to do is the baseline care. And this paper in clinical practice neurology clinical practice, expected to underline that. It's a fantastic program that you had, and I must say I learned quite a lot, starting from the diagnosis up to the most recent drugs, and must thank all of you for that. Thank you.
Basically, being the theme is also breakthroughs begin with you. I think it's important to understand that, we have to do a holistic multidisciplinary management. Dr. Lakshman has asked who is in from Nepal, but he was alumnus from AIIMS. He's asking who bears the cost. Out of the experience which I mentioned, the nusinersen 47 are all humanitarian access programs. The Global Direct Relief had initially in India identified 30 patients and later 200. So out of 230 patients, 47 are ours. So we have that experience. Another is Diplam. We had 5 on humanitarian access programs from Roche, and 4 of them had got it from the crowdfunding. And the third was you asked about the gene therapy. Actually, 15 patients of ours have got selected from the humanitarian access program. And but the 2 are still pending to be given. What 15 I said was they all were, we've had 13 from the humanitarian access. 1 got from crowdfunding, and he went on to KBC. And Farah Khan had taken it, and Amitabh Bachchan had shared. So he was lucky to get. But let me tell you, one crowdfunding success has thousands crowdfunding failed because a patient came to me, and I was told that their parents are sitting outside the Puri temple and begging, and they can't beg for 16 crores. So, I mean, it's something very sad. And that's why we need to know that it's multidisciplinary care has to also go. And 1 patient got from Coal India, and another patient has got this approved from another private sector, Solar Energy Corporation, but he is also pretty sick, and right now they're just in the process of transferring money to the Novartis. So I mean, we don't have that is how we are trying to do. And somebody has asked, I'm walking, what should I do to walk further? Do you have SMA? Who's this patient has SMA? You're talking about a patient who has SMA? It's okay. I think nothing you can, I mean, whatever you want to advise, they have to continue doing the normal walking, and making them do excessive or less is not going to change the outcome. You have to let them do normal activities is what I feel. Dr. Bhavuk, if you're there was a question for you. Can you hear Dr. Bhavuk? Dr. Bhavuk? It's okay, I think, but we're not. It's not that the things become weak. The only problem is when you get any of the spinal surgeries done, because you are going to immobilize for long time, some time. That's immobilization is a double-edged sword in the sense that time because the muscle becomes inactive that time because you're going to stabilize. Those are the issues which come up in any neuromuscular disorder going to have any kind of surgery. Sir, isn't that your experience too? Because you're going to be immobilizing that, and that is the only thing. Otherwise, it will not worsen. I mean, it is just that because it's going to be disuse So whatever, anyway, they are already weak, and you are not, you're making them rest by, immobilizing them post-surgery or in a brace. That becomes a double-edged sword. That is the only thing. Anything else in this question you feel, Dr. Khadilkar sir, you want to say? Because
no, I basically tell people to do 80% of what their energy is. The person who is asked, can he continue to walk? I generally say that you do 80% of what you can so that you don't overexert. Because in a lot of cases, it becomes mind over body. And they just go on doing more than what they should. So I sort of tell them this 80% rule, do 80% of what you can in all kinds of physical activities. And that generally holds good, not only for spinal muscular atrophy, for all the neuromuscular diseases. Yeah.
There's an interesting question in the chat.
Ma'am, you're muted. You're muted.
No, Shefali is muted, yeah. So there is an interesting question in the chat. With newer
Please reply.
therapies available, how do we counsel in case of antenatally diagnosed SMA in India? So I think, see, whenever we are counseling in genetics, we do not tell them what to do and what not to do. But most of the time when they are taking prenatal testing, they decide beforehand if the patient baby is affected, they're going to terminate the pregnancy. There are exceptions, rarely in India, but they are more maybe abroad. And interestingly, there is a Pompe fetus has been treated with in utero enzyme therapy, and the baby is doing very well post delivery as well, receiving enzyme. And there is a move towards in utero gene therapy also, because, and then it is likely to be more efficacious because the fetus doesn't mount a very severe immune response. But that's not a practicality as of now. So in this situation, we do counsel the family about the possible therapies when they come to us for counseling before pregnancy or during pregnancy. But most of the parents would opt for termination of pregnancy if the fetus is affected, because they know that the treatment is expensive and the availability, if it is freely available, then maybe many of them will opt for continuing with the pregnancy. But in the present scenario, they would not. But definitely the decision has to be taken by the couple themselves, what they want to do.
Yeah, there is a 15 years follow-up going, Dr. Sayukta, not only 10 years. So in that, obviously, 15 years. So that is there. What I'm saying is, yeah.
It's a very difficult situation to deal with. They are getting the nusinersen as a part of the compassionate use. Now they want to stop it to become pregnant. I had to throw
that
away
we'll
one.
read. No, we'll read. We'll read about
yeah,
it and I'll discuss and get back. I think I am really grateful to everyone, and I think we are already 28 minutes post time. We'll just wind up in 10 seconds message, Dr. Khadilkar sir. Take home message. To wake up everybody who is sleeping, if at all. So I think a take-home message has to come. I don't have a hamper for a rapid fire, and neither are we doing, but because, and one thing I wanted to say, ma'am, we have a SIG on fetal and neonatal neurology. Keeping in mind the fetal neurology is coming in a big way. So we actually wanted to have fetal neurology separate neonatal, but we had to combine some SIGs because we were getting too many SIGs. So we have now listed as 9, and neonatal, SIG, neonatal and fetal neurology. And I think that'll be interesting. We'll be posting. Yes, sir. Sorry. So you'll be interested in fetal neurology, sir?
The shortest is awareness. Awareness at all levels. Awareness at how to make the diagnosis, how to make the genetic diagnosis, how to make the multidisciplinary team work, to realize that the neuromedicines are there, but they're not Asia. I think awareness of the whole thing, that's the take home message. Yeah.
Sir, and when we do the fetal neurology, I'll send you the day so that I think you'll be interested. You have done all adults, so you like to go to the fetus and see now.
Yes,
the Madhulika.
Yeah, so I think still, despite therapies being on and working in genetics, I would still like to pass on the message about genetic counseling and prevention of the birth of another affected child if the parents want it. I mean, obviously it is voluntary what they decide, because if we plan to treat children who are born, we really need to reduce the number of the babies born with severe disease. So, I mean, this is one message. So for all of us, counseling is extremely important to tell them about the risk of recurrence and the reliability of prenatal testing. Obviously, decision is to be taken by the parents whether they want to undertake prenatal testing or not. That's from my side. Thank you.
Gurpreet.
Well, as Khadilkar sir said, awareness. So I was aware of a lot of new things today. One thing
Same ना बोले कुछ नया बोले. थोड़ा message
I want to say that कि जो MDT का concept है, that is more of a retrospective concept which I am seeing in private practice, because the patients, when they get some things like Risdiplam and Zolgensma, only those patients are getting MDT because they are being taught and followed up by company people and they have the access to everything. Other patients, those who are not getting targeted therapies, they are also not opting for any of the MDT care and they leave their children as such. So that is the
That's not nice. We have to, we have to help, support and everything humanistic aspect.
Only to big institutes and big corporate sectors, but otherwise the situation is not very good with MDTs.
Gurpreet, no, but then your SIG has to give recommendations and guidelines, na? Practice parameters for all the categories. And I mean, I thought not long ago you were my resident and now you sing private practice, so pata nahi bahut, right?
This is one fact.
Yeah, Anuja.
Yeah, so I would say, being a nutritionist, that nutritional, aggressive nutritional therapy is as important as a medical therapy. And we often sideline nutrition. It's not just supportive. I think it is a very vital component of the whole management of SMA.
So without nutrition and without development, you cannot have pediatrics. So, right, ma'am? Dulika ma'am, you remember the statement? Without development, without nutrition.
Yes.
Yeah. Sanjukta.
Thank you. Regarding what Dr. Gurpreet said about multidisciplinary care, when we started this multidisciplinary clinic in our hospital,
Sanjukta, one line.
So
Yeah, it is 10:05. They'll kill me. I mean,
more multidisciplinary units everywhere, all through India. We need more of that. It is not very difficult to establish.
Yeah,
and
yeah.
it shouldn't
and you know
be,
what?
it, people should not be coming to big cities for that.
No.
I think all the medical colleges should have a mandatory multidisciplinary care unit for neuromuscular diseases. It's possible.
Sanjukta, you'll be involved in those guidelines they'll make. Neuromuscular. Renu, Priyanka, please note it. Priyanka is the member secretary, right? You'll be involved, Sanjukta, so that your guidelines can be made. Soumya.
Unmute
Mute
yourself.
Unmute. 10 seconds. Unmute करके 10 seconds. 10 तो निकल ही गए. बोलो जल्दी.
Thank you, ma'am. Okay, I'm so sorry. I realized I was mute. Thank you so much.
No,
it was very wonderful and informative. And, nutrition to medications and rehabilitation, everything is important. We recommend a multidisciplinary approach. Thank you so much for the initiative.
Mahesh.
Nothing to add, ma'am. Like it was very well discussed, ma'am. All the components are very well discussed, ma'am.
Okay. Dr. Anita. Priyanka. And then back to Renu. Dr. Anita, Dr. Priyanka.
I think it was an eye-opening thing, not writing only the medicine, but getting into all the things. I think respiratory is the one which has been very much stressed. And I think we have been ignoring it. Nutrition, immunization, I think as a part of pediatrician, we have been, stressing on. But I think pulmonary is one thing which was really eye-opener.
Priyanka.
Ma'am, I would just like to add that collaboration is the mainstay for multidisciplinary care. And it's high time that all peripheral setups should also have these multidisciplinary teams who can take proper care of kids with SMA.
Dr. Mary? Dr. Mary, you want to add something?
I think we should try to find out why some children do well on Zolgensma, some do not do so well. And also, we would like to know why some children do well on vestibular and some do not do. I think that is one thing that we all should look at. Thank you.
Yeah, definitely. I think, we'll be writing ours at least, so we can just keep it and note it down. And isme se kaun hai? I mean, so we can just see and as what was the things, and otherwise that's why Dr. Madhulika was saying the biomarkers, trying to see which biomarkers which help in diagnosis, which will have prognostic implications and all that. And Renu?
I think message should go to the parents that these are not magic bullets. So a score of 1 or 2 increase may not really change their lives. So they have to follow these 9 steps before jumping to the 10th step. So this is.
And there is plagiarism. That was my line, yeah.
I have started with this, that they come directly for the 10th step and they forget the 9th step. So
there's some 2 patients of post gene therapy are not happy because they expected ki wo bhagega utke, I mean, they're not understanding realistic expectations. We were happy because it's improved, but they are very dissatisfied. One of them.
Yeah, so because we also saw her Nielsen data, the improvement was 4 point or 5 point. So they hardly make changes in their life. So that's why.
But they will make over a period of time. But the only thing is we have to see overall. I mean, but still SMA is a much better response than other neuromuscular. Right. Thank you so much, everybody, thank you very much for all of you for joining. We have crossed it by 36 minutes, although we started 7 minutes late. Thank you, everyone. Thank you very much.
Thank you.
Mahesh, we have next week also, we have neuromuscular. So it'll all coming up. Yeah, thanks.
Thank you.
Bye.
Night.
Thank you, sir.
Thank you. Bye.
Thank you, Khadil Krishna. Thank you. Thank you, ma'am.
Thanks, everybody. Good night.
Good night.